Welcome to the Pharmacist RN, a podcast made for pharmacists by pharmacists. Pull up a seat and let's get started.
And we're back with another episode of the Pharmacists RN. I see Ajit laughing on camera here. Every time you hear that soundtrack, I know it gets you fired up. For
Brings
the
me back
audience
to
members,
Tomorrowland.
I may not know. That's a very famous EDM band that did that for Ajit and I as a favor, as an intro to the show. But we're back now for part two of kind of a two-part series on diabetes. We're fortunate enough to be here with Michael Boivin, who needs no real introduction. Obviously, my co-host Ajit out of BC. Michael, I was listening to kind of as we went through our last segment. Ajit won't know this, but I have access to a lot of kind of healthcare providers, obviously doing the stuff that I do. But if I ever have an issue with my kids, my family, myself personally, the first person I message, Michael will know this, is I message Michael, because whoever heard our last segment, you think this guy's an expert only in diabetes, but he's not. He knows a lot about everything. I don't ever remember meeting someone that has so much knowledge across so many therapeutic areas, and it's actually an absolute pleasure here, Michael, to have you back again to kind of continue our discussion on diabetes. But really, today's focus will be kind of some of those practical therapeutic pearls, what the community pharmacists working kind of in the real world in a busy environment, some of those things that they could take back and really have an impact on their patients, and try to kind of apply some of this knowledge and some of the guidance that comes out of the new diabetes guidelines.
I'm thrilled to be here, John. Thanks so much for having me. That's very kind of you to say that. I always say I'm an expert in nothing, but I know a little bit about everything, right? So it's kind of like every other pharmacist that's actually probably listening here. It's that we have to deal with everything, so it's an opportunity to do it as well. So
yeah, when I think about diabetes and what the diabetes patient means to a community pharmacist, they're a huge part of our business. I think they're very important. Obviously, from a chronic disease perspective, we see many of them, but they're also important to the business of pharmacy. This makes up a big chunk of your patients. And I think as a business owner, I always want to make sure we're providing the best possible care to those patients, because we see them more frequently than anyone else. They're in and out of our pharmacy like a minimum of 12 times a year, probably more. And, depending on the type of patient you have, I find there's always an opportunity. And I think, for us here today, I just, I want you both to start thinking about, okay, what are those two or three things that our audience could take back? Because I'll tell you, we're in kind of the busy flu season right now. We're probably seeing, we're filling 600-700 prescriptions upstairs right now. We've got, it hasn't really died down this flu season. It's still lingering. I don't know what you're seeing, Ajit, but I'm still doing probably 100 to 150 flu shots. 70% co-administration with COVID still. So it's a busy place. And when you have these patients with diabetes coming in, you want to make sure that you're offering the best possible care, but you want to do it in an environment that's very busy, and you can't spend that much time with them, right? So how do we optimize the little bit of time that we have with these patients? And that's kind of what we're going to talk about today. Ajit, you seeing the same thing out in BC?
Yeah, I think John, you hit on some really good points. I think there's a lot of opportunity. There's a lot of these clinical encounters we're having with patients with diabetes that go beyond dispensing. You do a lot of point of care testing. I do a lot of vaccinations, and when we look at comorbid conditions, diabetes comes within a whole plethora of conditions, including potentially CKD, cardiovascular risk, and we talked about that a lot in our previous episode. But it's just about, how do you manage your time, right? So how do you manage your time? And you know what, Mike, I'm going to steal something that you wrote in your in your show notes, your prep notes. Is you had a colleague named Alice Chung, right?
Alice is actually leading endocrinologist in the country.
Oh, there you go. That's why that advice was so pertinent, is do something, right? So even if you give your diabetic patient a flu shot, or you help them with a new medication, it's very valuable. I think pharmacists can certainly have the potential to do more. I think that you've just got to manage your time and manage your encounters. So that's where me and Mike talk, and John, we talk about this a lot, is you should know who your patients are before they come in. You should know your roster. And that's where pharmacy assistants, students can help identify patients who can benefit from that conversation, because it starts with the conversation. If you listen to our previous episode, there are a lot of potential gaps. And as Mike said, it's nobody's fault. It's just the reality that this is a complex condition and there's just so much that needs to be looked at. So that to me is the first step. That's the way I always look at it, is when someone's coming through the door, I should know a little bit something about what I would want to talk about. And in BC, we have medication reviews. In Ontario, you have diabetic meds checks. I think that's a great place to start. I think that's a great place to start, where you actually have time to sit down. There's compensation for your time, but you should be having very strategic conversations. I think you should be looking beyond at the BPMH. I think you should be looking at some of those gaps in monitoring, gaps in tolerability, and gaps in optimized pharmacotherapy. So I feel like that's a big thing. And the other thing is individualizing care. So the nuances now in diabetes, a diabetic patient is different than this diabetic patient and this diabetic patient, regardless of, their medication regimen. They might have other comorbid risk factors. They might have certain lifestyle challenges per se. So it's these sort of value-based goals. And Mike, you do such a great job of talking about that, and really addressing that on a more individual level once you find out your roster of diabetic patients.
The only thing I love the way you're going with this. The key thing for me is that I look at, and I've been a pharmacist a long time, and I look at all the pharmacists, and we look at a person that comes in. It's like a person with diabetes could have potentially up to 30 to 40 problems that are there that you want to address all of them at a time. And the key thing here is, what I hope on this episode is we can provide you some tips that if you just do one or two of these things to start off with and just kind of build upon that component, you're going to change the course of the disease. You're going to feel more comfortable with these patients. You're going to actually start with something and then kind of move from there. Because if you start to try to do 30 things at a time, it's completely overwhelming. So if we just talk to you about statins, for example, and how that fits in, that could be an easy thing that you can work with your team and implement. Start to do that over a few months. And then if you feel comfortable with that, move to the next level. Remember, these are chronic diseases that people are going to have for the rest of their lives. Thus, we have some time. It's not an absolute panic. So start where you see that priority is and what you feel comfortable with, and just kind of keep moving from there. So as we share these tips, don't feel you have to do everything. Start with something, do something, and then keep moving on from there.
Yeah, I like your statin tip.
Yeah. This is right. I think, God, we started thinking about the same thing. So this,
I know.
this is, I see this every day right now. So I'm going to throw this one out there. So I've got line up for patients, they're waiting right now for their flu shot. We take walk-ins as well. We don't really turn anyone away. So while they're waiting, sometimes we do an A1C, and I get these patients, patients with the diagnosis of diabetes, typically on metformin, maybe not anything else, haven't had an A1C in probably 2 years. They're coming in for their shot. One of my students will do it. Their A1C comes back, 8.7, take me through that process, Mike or Jit, or both of you. Like, what do you start thinking about now? Because you've got probably 10 minutes with that patient. What would you suggest the pharmacist start to think about?
So you were both eager to jump at that one.
Yeah.
Well, I think unfortunately, John, that with the pandemic, and I've noticed this even looking at Care Connect in BC, the A1Cs are not being, they're not being either. They might be ordered, there might be a standing order, but people aren't going for blood work at target. So this is something that actually, to be honest, I would actually go back pre-pandemic and potentially see an 8.7, and now, years later, I don't know what it could be. But I think it's important to, first of all, let the patient know that this is an important thing to monitor, like what exactly glycosylated hemoglobin A1C is, and what it's used to measure in terms of what we can do about it. Last episode, Mike had some really good recommendations about this sort of ongoing diet and lifestyle. That's an ongoing recommendation. But first thing that comes to my mind is, what are we optimizing with pharmacotherapy? We're pharmacists, we're drug information, medication information experts. So I would look at that patient's current regimen. I would see, are they adherent to their current regimen? And then I'd be looking at some of the guidelines to see what we can optimize. I'd even go one step further, because in BC we can't prescribe per se, not yet, for chronic disease meds that are beyond renewals. Because in this point, if I'm renewing the patient's meds and they're adherent, that's not going to help bring down their A1C. And also A1C targets do fluctuate. 7 is sort of the standard, but it's different for everyone. If they're frail, they're elderly, they might run a little higher. And things like that. But assuming our patient doesn't have any, different targets, I'd be looking at pharmacotherapy optimization. And I've been doing something since I graduated that's worked really well for me is I fax physicians a consult note. I don't have to necessarily type it up, long things each time. I have a template. And I find physicians, that's the language they speak. They get something from their primary care, gets from cardiology, gets from endocrinology, the whole thank you for allowing me the opportunity to see your patient. I reviewed their A1C to be this, or their Care Connect, or their point of care. I recommend this agent based on these guidelines that Mike talked about in the previous episode. So go listen to that. And I have a lot of really great, and they book an appointment, they bring that in, or even if I fax that in, I tell them to go see their doctor just to, keep that continuity. But I find that physicians start referring patients to our pharmacies because they know that their patients are taken care of. So could I do that in 10 minutes? For the first time, no, but you get in the habit and you train your brain to immediately look at pharmacotherapy, ask the right questions, and have templates, have your staff or students fax that out. So it's definitely doable in 10 minutes over time, for sure.
Yeah, and it doesn't have to be 10 minutes. I was going to say, we've got the funding here. You might have to ask them to come back or whatever, but we do have diabetes med check. Sorry, Mike. Yeah, you're going to add to that.
Yeah, no, I think Ajit brought up a lot of really good points here. And like the first question with that one is an 8.7. So you have somebody that's at least 1.7 above target. So I can just tell you with the data that's there, like if you look at SGLT2s, sulfonylureas, DPP4 inhibitors, you're going to lower their A1C by 0.4 to 0.6% on that one. So this is somebody that's like 1.7% above target. So the first question is always the same. So as a tip, check on the adherence of these patients. Hey, by the way, have you been taking your metformin every day? Like that's what many of my patients miss occasional dose of metformin. How many do you miss in a week? So just to find out what's going on, because when you see somebody like that, that's quite a bit above target. And then the issue is that if you don't bring it up, and I can just tell you from personal experience, if you don't address that issue with a patient, then they're not going to think it's overly important. So if you just come up and say, listen, you're about 1.7, you're above target of where we really want you to be, and this could be a problem for you in the long-term future. You know what? I would really like to work with you to actually get you to a level that is going to lower your overall risk, because I really want to make sure that you're around, your eyes are around, your kidneys are on, your feet are around, so that you don't have problems in the future. Can you come back? And we would love to end up having that conversation. Because again, a 1.7% A1C, you have a large portion of people with diabetes walking around with this. It's not imperative that you address it during a flu clinic. But this is something that you want to bring into the attention, that it's important, that we really need to address over that period of time.
Definitely.
That's great. Yeah, so I was going to say, so you do that, Dan. So we do that, and we make the decision, are they going to hang around and do it? And, sometimes we have the capacity to do that. Other times we don't. But say they do come back and, you sit down, you're doing the diabetes medication review. You see, they're not on a statin. They're not really on anything to protect their kidney. They're just simply on metformin. Kind of, how do you walk me through the next steps, Mike? Like, what do you do next?
So I think it's for people that are not really familiar with diabetes management. So some people that are going to be on this are going to say, oh, what am I going to do? So if you're not familiar with it, we're going to include in the show notes, there's the ABCDSS from Diabetes Canada. And this was actually developed within the 2018 guidelines that are showing this is proper diabetes care. So let's just kind of step through these components. And you don't have to focus all of these all at one time. So first one is A1C. So for most patients with A1C, you want to have an A1C less than 7. So one issue that's there. I usually, especially for somebody who's been diagnosed less than 5 years or younger individual, push them to try to get to less than 6.5. And the reason why is that it protects their kidneys and protects their eyes. And with agents like GLP-1s and GIP and GLP-1s, we can get these patients to target fairly easy without the hypoglycemia. So that is one way to push, and that's really, we want your eyes and your kidneys to be around. But if they get older, we can be a little bit looser with those targets. So if they're becoming they're functionally dependent, or they have frailty, or they have limited life expectancy or dementia, we can be a little bit looser with those overall targets. So you can customize over that basis. So that's where A1C fits in. Blood pressure, the next one, it's an easy one. We all have blood pressure machines within the pharmacy. These patients should be shooting for a target of less than 130 over 80, and it's less than 130 and less than 80. It has to be both of those individual targets. And that can be done with using ACE inhibitors, diuretics, calcium channel blockers. So it's an ACE inhibitor ARB first, then it's a dihydropyridine calcium channel blocker like amlodipine. And in those individuals, then we could use something like diuretics. Multiple agents are usually required to get them to target. And that's really crucial. We know that blood pressure across the course of the disease, the older we get, the more impactful it can have in terms of their overall outcomes. C is for cholesterol. And cholesterol, we look at the CCS, or the Canadian Cardiovascular Society, updated their guidelines in 2021. Things that I will let you know, for those of you who have laboratory values, we're looking at LDL. The target for LDL is less than 2.0 millimoles per liter. What they're saying in their guidelines, if the patient has an elevated triglyceride, it doesn't actually, LDL doesn't capture the overall risk. So they're using non-HDLC. So there's no extra calculations. There's no extra lab values. You just take the HDL, HDLC, subtract that from the total cholesterol that gives you non-HDLC. We shoot for that for a target of less than 2.6 millimoles per liter. And that's for primary prevention. It's tighter targets for patients that have already had a heart attack or stroke. The key thing here is just to let you know that every single patient is an easy intervention. If they have type 2 diabetes, or diabetes and they're 40 years of age and older, or if they're 30 years of age and older and had diabetes for more than 15 years, they all need a statin. Even if their cholesterol is good, the numbers are good, no issue whatsoever. They should be on atorvastatin or rosuvastatin, because that's been shown to reduce the risk of a heart attack or stroke. If we focus on D, which is drugs, we talked about in the first episode, SGLT2 inhibitors and GLP-1s for patients that actually have cardiorenal complications, and where you end up using these overall agents. And then if the patients had a heart attack or stroke, we would use aspirin along with them. A key component is an ACE inhibitor, or ARB, should be used in patients who are 55 years of age and older, or have any cardiovascular risk factors, because it's cardiovascular protection. Even if their blood pressure is normal, we still use them. And the drugs that have been shown in trials, telmisartan 80 milligrams, perindopril 8 milligrams, and ramipril 10 milligrams. So then if you keep going on that, then it's exercise and healthy eating, which we can always recommend for our patients, stress reduction, distress, and those overall components. And then finally, smoking cessation, which is a passion of mine that I work on constantly. It's that you can have an intervention. So we know that smoking increases the risk of developing diabetes and poor control and complication risks, especially the heart and the kidneys. Things such as your patches, your gums or lozenges or sprays are all safe to use in people with diabetes. Varenicline is safe to use in diabetes. The only one I get anxious about is sometimes bupropion, because it can increase the risk in patients at hypoglycemia of having seizures. So the rest of them are generally fine. So if you can help the patients quit, and you can see all of those are easy interventions, or relatively simple interventions that you can do, and you don't have to do them all at the same time. So if you just pick that up, that ABCDESS, and work on one of those at a time with a patient, you are changing, again, the course of the disease, the risk of complications of these patients. And again, we focus on drugs, but it could be any one of these components that you're focusing on as well.
It's a great overview. And yeah, you don't have to necessarily do all of those in one visit. I know, pharmacy students have hours to do workup, so they can go, they can write all that out. But typically, if you're with a patient, I think even patients, that's a lot of information to take in one visit. And that's where the longitudinal care comes in. You need multiple visits to manage this chronic condition and protect against micro and macrovascular complications across the lifespan.
We think of it as a single interaction, Ajit, to that point. It's always that single interaction. That's how we're paid in pharmacy. It's a single interaction. But in reality, this is a journey that we're taking along with the patient, and we're going to be there to help you along that journey. So it's, a good analogy to think about is if we're climbing a mountain, we're there working with the patient to climb to their treatment goals, which is at the top. We'll work each individual step. We're there to support you along the way, versus doing everything and then pushing them to the top, which never seems to work.
Yeah, great points.
I was going to say, Michael, so say we get, and I'm sure we have a group of audience members now that have access to Clinical Connect here in Ontario, definitely out in BC, other parts of the country as well. that exact same patient now, what goes through your mind if you're like, I've got some time here, I'm going to go in and see, what he or she has with respect to lab values. What are you going to look for?
Well, let's go easy, right? So
Yeah.
Ajit brought this up. Really, one of the easiest thing is looking at A1C. So you will find if you start to access this value and you talk to pharmacists, is like there are many people 18 months in between those values. So again, stressing the emphasis of these patients to go in, and to your point, John, there's an opportunity for point of care testing. That's the easiest one to begin with. The next one that we would focus on would be looking at EGFR. And then we talked in the last episode about KRFE, which you can calculate for those patients based on ACR, EGFR for those patients and their age. That is the next one. So we'll look at that as well as ACR. So that urine test, we want to make sure that's there. So again, those should be done at least annually for those patients. Statins, we want to make sure that cholesterol is done. It's normally done at least once a year. So make sure they're reaching target. So there's no problem. So again, target LDL-C is less than 2, non-HDL-C is less than 2.6. The latest one that I can just tell everybody it's coming fast, is looking at MASLD. So metabolic dysfunction associated steatotic liver disease, or MASLD, or non-alcoholic fatty liver disease was the previous terminology. If you can get an AST, which unfortunately in Ontario, patients have to pay for, but an ALT, it's like $10 or $11. It's really not expensive. ALT and platelets, we can do a FIB4 calculation. A FIB4 calculation is just a way of actually identifying patients that it could be at risk of fibrosis that are occurring in the liver. Fibrosis in the liver increases the risk of cardiovascular disease, and increases the risk of cirrhosis, and increases the risk of cancer within the liver. So these are the ones that we're starting with as being the key ones that I would really probably focus on. And that the one with the MASLD, I can just tell you, it's coming with a vengeance. We know about 25% of Canadians are living with this condition, and we're going to have pharmacotherapy that's going to be able to reduce and improve outcomes. So the earlier you start to integrate and have that conversation, the bigger the impact you can have for your patients.
So yeah, I would definitely agree with Mike. And for our BC audience, I've got my my lab requisition form here. Rusty, and basically we would be looking at some chemistry stuff. So that would be what Mike was saying. For example, hemoglobin A1C is under chemistry. ALT and AST are covered by MSP, so that would be something we could order. Also looking at full lipid profile, and then as Mike mentioned, the albumin creatinine ratio under urine tests. And you talked about that last episode where that's not necessarily a blood test. So asking patients, if you don't have access to labs, asking them when was the last time you did a urine test for your diabetes. And when I order this test, I make sure I tell the patient they're getting a urine test at the lab. So even if I order it, doesn't mean they'll actually get it. So I think that's really important. So lots to look at for sure.
And to your point, that's a really important, because like I've been around a long time, and when we used to do urine tests, that was checking to see if the person's spilling glucose within the urine. And we always told patients urine tests were garbage. To do a dipstick was a waste of your time. So then you're telling some of these people that have this disease that we need another urine test. And they're like, why am I doing this? There's no value to it. No. This is for checking on your kidneys. So you just have to clarify that component, because patients may think that there's no value to this test.
Yeah, definitely.
So if you know it, so I mean, Ajit's got the ability to write that lab. We don't here in Ontario, and many provinces still do not. What would you say? So if you notice someone hasn't had a kidney workup done, and you're sitting with simply an A1C, maybe a lipid panel there, are we referring those patients back, Mike? Or like what would the recommendation be then?
So I think really, John, it's a really good point, because you're going to find this for a lot of these patients that are falling through the cracks because of lack of primary care clinicians. So, or lack of access, they just can't get in. So the issue here is that I would take a look at it and work with the patient to prioritize what you want to focus on first. So what could that be? Could that be focusing on the pharmacotherapy for managing the disease to get their A1C under control? Could it be a kidney risk reduction for this patient? Could it be blood pressure or cholesterol? Find one of those things to really start with, and then kind of work with that process. So if I have somebody that has chronic kidney disease that's there, that are not optimally managed, their blood pressure is elevated, everything else, I can work with them on one of those components. But really, I'd want that patient to go in and get that full workup, because we know this disease will progress relatively rapidly if we don't actually look at these overall interventions. So the chance of this patient progressing to dialysis and failure are quite high. And from a holistic approach, or looking at over a healthcare system approach, dialysis is a huge cost to our healthcare system. So we're looking at pharmacists for, from a business perspective, we're looking at funding. How are we going to get funding? If we can prevent patients from getting dialysis, there's going to be more opportunity or more funding for this one, because as that increases, that's just going to eat in terms of the overall funding that we're going to have for healthcare. So these interventions are going to not only help this individual, but help the whole healthcare system as well.
I couldn't agree more, Mike. And it's all about, we talked about in the last episode, stopping that train into end-stage renal disease, delaying as long as we can, which I think is great. And I'm going to do a vaccine plug because I have to do it. But making sure your diabetic patients are up to date on their vaccinations. We do have evidence, clinical data that reactivation of herpes zoster has been shown to accelerate into end-stage renal disease. So any sort of acute infection, assault on the kidneys can push that further. So I would say I would definitely agree with Mike, because that great resource that you shared, Mike, the two biggest contributors to end-stage renal disease is uncontrolled hypertension and poor glycemic control. So even if we can't, I can, but even if in jurisdictions that can't order lab tests and find out where the kidneys are at, start with controlling the hypertension, control the sugars, and update the vaccinations. You're doing positive things and not waiting to see where the kidneys are at. We're thinking longitudinally.
Yeah, and to your point, Ajit, if you just come up and you say, I don't have lab access, what am I going to do? It's like, you have a blood pressure machine. Just have the patients to say, what, I think it's really important that you go and get your blood pressure. Every time you come in here, take your blood pressure and provide that slip with me. I want to know what those numbers are. And it shows the value of how important this is. And then also it's like, okay, now I showed you that you're elevated. You've been elevated for a period of time. Let's do something about it, and we'll work together with that component. So it's really starting that process, and that's an easy intervention that most pharmacists can do.
Definitely.
So it kind of, okay, as we progress through this patient now, so we've got a patient, he come, I either send them away with a rec, or they go back to their doctor, and now they come back and we see that they may have, their kidney disease may be progressing. What do you do next? How do you select the next agent? I know you talked about the guidance on the last episode, but if you're in practice now, what's that one recommendation you would make, or what's your thought process behind that?
Yeah, I think that the key thing with it is, so we're going to share with some of the resources that are available for patients with chronic kidney disease. But really, if you're looking at somebody with chronic kidney disease and that's what your focus wants to be, is really, you can talk about dietary interventions for those patients. There's a lot of great handouts that can be given. SGLT2 ACE inhibitor and ARBs for that patient, as well as a statin. Almost every person with diabetes with chronic kidney disease is going to require a statin. So those are easy, and those are first line. So that's what I focus on first. And then really what you want to do is make sure they're getting good glycemic control, and we don't have, because flow is so new with semaglutide, where that's going to fit in. My gut feeling is that we'll be initiating that fairly quickly and looking where finerenone fits in. There's still some question of whether we initiate all three of these like we do in heart failure for patients all at the same time, or do we start with one and then just kind of add those others? And I don't think there's a perfect right or wrong answer. I think that for me, it's usually easier for patients. These are slowly progressing diseases. We can start with one and then kind of go to the next one, and then add the next one as that patient requires it. And then it all comes down to coverage and other factors that can come into play.
Oh yeah, for me that came right to mind. I think it's easy for us to say just load them up, but man, it's hard in practice. I still see that resistance, particularly with diabetes. I think I've got a big seniors population here, so they like to move slow. If you give them too much, they start to panic, or they think you're not telling them everything, right? Yeah. So it's like one at a time.
And to your point, John, I think if you have an older adult, or you have somebody it's even in my age group, so you're looking 50 plus, and you're going up and one of those big interventions, you're going to start injecting every week. So if I'm going to give them semaglutide, that's a pretty big change. So let's let some time to process that. And then we're going to be titrating this dosing over a matter of months. So there's lots going on over that period of time. We're going to be constantly changing. So again, we're focusing on long-term interventions. So it's start with something and just slowly go in and adjust based on the patient. You may be only able to do 2 to 3 interventions a year, where in some patients you get 2 to 3 interventions on the same day. So it really depends on that individual and customized based on it. We focus on fixing everything. So you think about the mechanic who comes with the list. The issue is that people are not cars. What we want to do is actually, this is a problem. We're going to get you, keep moving on that path to make you the best person you possibly can be.
Great advice. Couldn't agree more.
Yeah, you know, for me, this sets up this whole opportunity about follow-ups. I think it's an underutilized part of our program here in Ontario is we have the funding and we have the ability to follow up with these patients, right? The MedChecks program has a follow-up program. It's easier said than done. Listen, I struggle with it as well, right? But you've got the opportunity now to arrange for these touch points with those patients. So you've got them in there. Maybe they were there for a vaccine or whatnot, but there's a ton of value in doing that. I find if you, and you know, every patient's a little bit different, but if they're regular patients in your pharmacy, try to schedule those next appointments. Be a little bit proactive, right? And if you're able to do that, you could touch on one of these things at a time as opposed to trying to tackle three, four issues all in one visit.
Yeah, and I think the challenge with follow-ups, John, just to add to your point, is that most people don't understand what am I going to talk about during that period of
Yeah.
time. So you have to have a set structure. Things that can help for that, for pharmacists here in Ontario, is that if you're using CGM data, so if you're looking at a Libre device or a Dexcom device, it's a nice review of what's going on. So it's a nice follow-up basis. Blood pressure is a nice one to follow up until the person's in their target range. And the nutritional interventions, there's so many great resources that are available that you can actually use and say, listen, we want to come in and we'll talk about physical activity and we'll talk about, what you can end up doing for nutrition interventions that can actually impact the care of your disease, your blood pressure, and everything else. Those are really easy ones to start off with. And that could be a handouts and then talking through how they can customize it. So it's at least a place to start. Because I think otherwise it's overwhelming. It's like, oh, this person's coming back with diabetes. What am I going to talk about? I need a structure. Whereas what we're used to is fixing all the problems at once. We're not trying to do that. We're going to do a little bit over the period of time. That's where that follow-up fits in nicely.
Yeah, and I want to add again, just agree with both of you. And I think one of the challenges with any follow-up, whether it's the BC Medication Review Program or the Ontario Meds Check, is that structure, right? It's follow-up is such a generic term. Yeah, I'm going to follow up with you. Basically, like Mike said, they're coming in, oh shoot, what do I talk about today? I think we need to build clinical into the word follow-up. And I think that for patients with diabetes, going through that list that Mike said, the ABCDS, can be a form of follow-up. It could be anything. It could be administering a vaccine. It could be assessing whether the patient's ready to start smoking cessation therapy. So I think internally, pharmacy teams need to look at what follow-up means and have more clarity when they're actually talking to patients and actually structuring that. Because the problem with follow-up is, same in BC, it's very underutilized. And again, the funding for a follow-up is about 20 to 25% of the initial visit. So
Yeah.
there's that aspect as well. And a lot of times that follow-up could take more time than the initial visit. So that's a whole conversation for how do we build funding, value-based funding models, because clearly that hasn't quite been established. But I think internally pharmacy teams can talk about what are some key things from a list of follow-ups that would structure into a next visit, just to give them some more clarity and structure to increase the volume of follow-ups that are happening for patients.
So I just want to add to that is that we also undervalue our own services from that standpoint. So, we may get 20 to 25%, but to do 20, 25% for doing a shorter intervention with that is, I think, fairly reasonable if you're just going to talk about blood pressure monitoring or CGM monitoring. It's that if you're going to do a whole intervention, like a series of interventions is not there. I think that what happens is that we have to be able to look at is normalize a process of pharmacist checkups. Like what we want to do is check in to see how you're doing. This is important to me. It should be important to you. We'll work together to develop a solution. I'm here to help you. I'm here to support you. And pharmacists don't think that way. We think about single intervention. We fix something today, fix the car and the mechanic, you're moving on until you have another problem, you come back and see me. And what this should be is a long-term relationship you develop with those individuals. And that's what that follow-up is established for. And if we think of that mindset, that we're going to do a little bit at a time over the course with that individual, working with them through a shared decision-making process, we can change, again, the course of the disease and what the outcomes are going to be for that patient.
That's a great point.
With that point, I was going to say, Jed, I see our producer sending his notes for going over time, but I'll let you have the last word.
No, I was just going to say, like, we could talk about this for hours. So I definitely want to see us re-pick up this conversation very, very soon. And obviously, Mike is just such a wealth of information. I've learned a lot today and from the previous episode. So definitely want to have him back for our audience. The only thing is, Mike, you mentioned something before the show that pharmacists make up the biggest healthcare profession demographic of certified diabetes educators. So if one is inspired by listening to these episodes, because a journey of 1,000 miles begins with a single step, if one's inspired at becoming a CDE, how would they go about doing so?
That's a great question, Ajit. So one of the questions first off is, should I become a CDE? Is the issue that's first. And the fundamental is that I look at a CDE is that I did my CDE course, and I did it because there's a level of credibility that it provides, and it's a level of confidence that it provides you as well. So I know that if I completed the CDE and passed the exam, then I know that I have the knowledge to be able to take care of patients with diabetes. Unlike other certification processes that are there, it's recognized by most primary care clinicians. I'm a diabetes educator. Oh, I'll start referring my patients to a diabetes educator. So I would encourage people to do that. The exam itself is through the CDECB. It is offered. It's a virtual exam now. I wrote my last exam actually, and I remember looking at it going, I'm too old for this. Like, as you're doing this on camera, and it's a very weird process, but it really gives you an idea of how well you know diabetes if you can actually do this exam. So I would encourage people that want to be engaged and they're like, I'm not really 100% sure. It forces you to learn all of these components. And it's really, I would strongly encourage people that are involved in diabetes management to actually consider that overall process. So think about it from the standpoint, it's not just about the care you can provide patients, but it's a confidence level that it provides you in terms of the interventions that you're making.
Yeah, and I'd probably say like professional satisfaction as well. I mean, all these certification, ISTM, CDE, I find a lot of students at UBC, and then they eventually get certifications. They find a lot of professional satisfaction having some niche expertise and having something that patients come to them for in their respective work environment. And the best way to prepare for these things is to do all the things we talked about in this episode, because that's how you log your hours, you build your clinical portfolio, your confidence. So you can start that process right now.
Yeah, I was going to say, as an employer, 100%. A ton of value. As an employer, it's one of the things I look at. I mean, the market, it is what it is right now, and pharmacists are tough to come by. But that will switch. I've seen it change a few times in my career, and when a prospective pharmacist, I'm speaking to them or interviewing them, there's a ton of value in that as an employer. I know that will draw people into my business, draw referrals. I actually, it's one of the things I look for. If you're going to write that test, I'm sure Mike had the highest score ever on that exam. I'd like to know your score. But with that, guys, we're really getting to the end of the segment today. So, Mike, I wanted to thank you again for taking the time out and joining us. It's always a pleasure. Obviously, a wealth of knowledge. To Ajit's point, we'll have you back. We'll have you back on some of our
and such a professional, Mike. So much.
I appreciate it. Guys, and you know what? If anything, we could teach anybody out of anything on this lesson is don't try to do everything. Just do something. And if that is where you start off with, pick up the ABCDSS, have that handout, focus on one of those components. If you do just that, do one thing, you can make such a huge difference for these people. Not only these people, but if you look at cholesterol and blood pressure management, it's a lot of your patients that you can have a huge impact. So focus on something and then work through that component. And if that's anything I can leave you with, that's what I love to see. And I really appreciate you guys having me for these episodes as well.
Pleasure
we'll end on that note. Subscribe, hit the like button. Thanks, Mike. We'll see you guys soon.